Hello everyone. This brief video will be an introduction to fractures and cast care for the pediatric patient. First, we'll go over how you know someone has a fracture. Often the patient will present with some kind of history of a fall or an automobile accident or other trauma, so we'll have a suspicion for fractures in the first place. And then the patient will of course be reporting pain. There's often swelling, sometimes bruising. And then if the bones are displaced in any way, there's going to be limited range of motion. So for example, if a patient breaks a wrist, they might not be able to move their fingers well. If they break a leg, they may not be able to move their ankle, their foot, their toes. So we'll look for limited range of motion that's distal to the injury point. If the bones are really displaced, we might see an obvious deformity of the limb. And then often we can find what is called point tenderness, where the patient might complain that, for example, their arm hurts, and we can palpate most of the arm and it's really not very tender for them. But as soon as we locate the site of the fracture, that is very tender for the patient. There are different kinds of fractures. So depending on the injury that the patient sustained, the mechanism of that injury, we might see different types of fractures. Now you guys don't need to memorize these fractures for me. The one fracture I want to point out to you though is the spiral fracture here in the upper row. This is often seen in cases of child abuse where someone has grabbed the child's arm and kind of twisted as they're pulling them, and it can break especially arm bones. It's not necessarily just child abuse either. We can see it with intimate partner violence and just any form of violence from one person against another. The fracture that we really only see in pediatric patients is the green stick fracture, where it's not the entire bone that's broken through. If you can imagine taking a twig that's still green and bendy and you kind of try to break it, it doesn't break the whole way through. Maybe one side of the stick breaks, but then the side of the stick closer to the bend actually remains intact and doesn't completely come separated. That's the same kind of thing we see with those young kids who have a high cartilage component in their bones still. We'll get that green stick fracture. If you do have a fracture that goes through the end of the bone, like you see here in this avulsed fracture, it can damage the growth plate. So for our young patients who have not finished growing, there is a potential that we'll have bone length discrepancies because of that injury. So that's something the orthopedic specialist will be following up carefully. Once we've determined that there is a fracture, treatment does sort of depend on where we are, but there are some basic principles no matter what setting you're in. So first, we want to be managing pain, whether that's PO medications, IV medications, just an ice pack, kind of whatever materials we have to work with, we will use. Some orthopedic specialists don't like to use ibuprofen for fractures because they're worried about the increased risk of bleeding that can come with that. But the more we do research on that, the more it seems that ibuprofen is safe for children. So orthopedics are slowly moving back towards ibuprofen, often in conjunction with acetaminophen as well. If the patient really has a lot of pain, we will often go to narcotics just for a day or two to get that initial pain managed, but we do try to keep that to a very limited dose in all age groups. Then of course we want to immobilize the fracture. So if you are out in the community or maybe working as a school nurse or somewhere that you don't have immediate access to emergency medical services, we'll want to use makeshift splint, whether that's an inflatable splint that comes in first aid kits, or even just a pillow taped around the affected extremity is usually very useful in immobilizing that. You want to make sure you immobilize the joint above and below the broken bone, wherever that might be. If the patient has a broken rib, then we can't exactly immobilize all of the joints in the torso, but it is often helpful for patients to use a pillow or a blanket or something to sort of hold against their chest whenever they have to cough or sneeze, or if they're laughing, to help brace that rib to keep it from moving quite so much. Once the orthopedic specialist is on board, they'll be performing what we call a reduction. That's making sure the ends of the bone are properly aligned for healing. We hope for a closed reduction where we can just use external manipulation to get the bones to line up. But if it's a really severe break, if there are several fragments, if it's extremely displaced, or if there's any kind of skin damage along with the broken bone, then the surgeon might actually do what we call an open reduction, where they make an incision through the skin layers, through the muscle layers, and then directly manipulate the bones instead of just manipulating from outside. An abbreviation you might see a lot in charts is ORIF, which stands for open reduction, internal fixation. So that means they, again, cut open the skin and the muscle layers, and then internal fixation refers to any kind of plate or pin that has been used to physically hold the bones together. There's also external fixation, where the pins go through the bone but then are attached to a frame that surrounds the patient's limb. That's usually more of a temporary solution, and I know you learned about the associated pin care last year in your classes. Whenever you do encounter a fracture, just keep your eyes open for any signs of abuse. Fortunately, most fractures that we see in pediatric patients are just due to the crazy shenanigans of kids, and they're doing things like falling out of trees or crashing their bikes, and they're perfectly innocent injuries. But certainly physical abuse in pediatric patients does often present as fractures, whether it's a fracture that doesn't match the story we're being told, or multiple fractures over a long period of time could indicate to us that there's something else going on. So we just always kind of take a quick look at the rest of the situation to make sure we're not missing any warning signs when we encounter a fracture. Most fractures are treated with some form of casting, whether before surgery or after surgery, if that was needed. So there's a video in the CoursePoint Plus that I have posted directions for you to watch in Canvas. It's an excellent video describing the care of the child who's wearing a cast. But I'll just hit a few high points with you here. So first, we want to keep the casted extremity elevated, and that's so that any swelling will actually drain back towards the heart instead of collecting under the cast. If too much swelling collects under the cast, then we can actually cut off circulation to the distal fingers or toes or whatever is the distal part of the extremity. And of course, that can lead to skin breakdown, impaired circulation, and could ultimately be a medical emergency. If your patient has a plaster cast, it does take a little while to dry, so you would want to make sure you're using open palms in handling the cast rather than fingertips. But if they have a fiberglass cast, then that dries almost as soon as the provider is done placing the cast, so you don't have that same concern. Always be observing for swelling, for numbness, for tingling, for any signs of any kind of impaired circulation. And make sure the patient is still able to move, whether it's finger or toe or whatever is distal to the cast as well. The provider might order restrictions of activities following the placement of the cast, depending on what the indication was for that cast. So make sure the patient and the family are well educated on that. And then we want to remind them to stay still, or at least reasonably still, for the fracture healing. The more you can keep those bones perfectly aligned, the more quickly that healing will happen. So we do want to just sort of limit the amount of jumping around that the child is doing as much as possible. A lot of casts are either trimmed to fit perfectly, or even just have little fiberglass edges that are really rough. So whenever you encounter that, we just want to make sure we pedal the cast. That's where we take moleskin, which is a soft, sticky fabric, and put it around whatever rough areas we encounter on that cast to prevent any skin breakdown. There's another video on Canvas for you to watch that is about pedaling specifically. Also, to avoid any fluid accumulation, we'll avoid letting the limb hang down for any length of time. And then it's really important to remind the child and the family not to put anything inside the cast. Little kids might do that just because they think it's a fun hiding spot, but most often kids are doing that because the skin under the cast is starting to peel off, you know, that dead skin cells are coming off, and it becomes very itchy. So they'll try putting things like pencils and rulers and hangers in their cast, and they can bunch up the padding, creating a pressure point, or they can actually just scratch the skin and create an open wound under the cast where we can't clean it. So they suddenly become at risk for infection. So nothing inside the cast, no powders or lotions or anything either. If the skin is really itchy, then they can take a hairdryer on the cold setting, no heat, just the air, and try blowing some fresh air inside the cast, and that can sometimes help relieve symptoms. With traditional casts, a way you can prevent that itching is to keep the cast perfectly clean and dry. So things like showers, bathing, swimming, of course, you would need to be really careful to keep the cast dry. But even just thinking about exercise, if your patient is sweating a lot, or if it's just a really hot summer, then we can get moisture buildup inside the cast just because of sweating. So we can't always exactly prevent any moisture from getting inside there, but we want to do our best. There are new waterproof casts. There's a kind with Gore-Tex foam that's allowed to get wet. And I've also put a link on Canvas for you to a new kind of cast that looks like netting almost, really thick netting. It's basically plastic tubing that they place over the affected extremity, and then they inject epoxy into this framework and it hardens. So you actually see most of the skin still, and you can get it wet, there's no problem with that, but it has hardened perfectly to maintain the right shape for the patient. So those two new kinds of casts, you don't have to worry so much about getting them wet. You just need to make sure you're cleaning them appropriately if you do get any kind of sand or dirt or mud or anything inside the cast. So that's it for this quick review of fractures and cast care. Make sure you go back to Canvas and check out the other resources I have listed there for you.